just putting everything.
I'm just right now. I'm just connecting to YouTube, so it'll be 1 minute. Well, the thing is, it's weird. I don't see Gabriel as accepted.
Okay.
So you should be able to see now that we're transmitting live on YouTube. Okay.
I'm just
connecting to YouTube, so it'll be 1 minute. We're on YouTube. The thing is, it's weird. I don't see. I just closed that window so that, yes, we're on YouTube now. Okay, as you can see.
Fine.
Hello, YouTube. Welcome to our webinar.
Hello, YouTube.
So, Javier, did you ask me for Instagram?
I'm going to start as soon as Lilia does the introduction.
Oh, okay.
So that it can be, and I will join, I will call you. I will start the live with facial team, so you have to press that connect, that link, and then you will add to the, and you have to ask permission to participate. Okay, there's going to be like an announcement, and you have to ask permission to participate. Okay.
Okay. So, but I have to wait for you, right?
Yeah. But if you want to start it, you can do it also. You can start, and I will add whatever you want. It's up to you. If you want, I can start, and then you join. Okay.
And we have 6 participants coming in now.
Okay, I'm ready.
Yeah. Okay. People are starting to come in now. Okay.
Okay.
And I'm just going to begin the recording now as well. So to the participants who have come in, welcome. Thank you for coming to our webinar. And we'll be beginning in just 1 moment. If you have any questions, you can write it in the chat button, and that will come to me, and I'll make sure that our speakers today get the questions that you have.
Just close this door here.
Okay, so shall I begin with the introduction?
Perfect. Whenever you want, Lilia.
Okay, well, welcome to our webinar on facial bone surgery. This is about how the discipline of maxillofacial surgery can enhance plastic and cosmetic treatments in order to obtain even more optimal results. The objective of today's talk is to highlight how multi-speciality, a multidisciplinary approach to aesthetic surgery, working with maxillofacial surgery, can reach new levels in terms of results. So we have here today Dr. Javier Gutierrez Santa Maria from Barcelona, and also Dr. Octavio Sintra from Brazil. I'm going to also now give a little information about their backgrounds before they begin their presentations and talks, and you'll have a chance to ask questions along the way. So Dr. Javier Gutierrez, who now works for a facial team in Marbella, Spain, is a maxillofacial surgeon who completed his studies and his fellowships in quite a few interesting places, such as the St. Jean's Hospital in Belgium with Dr. Professor Momeyerts, also in Baltimore with Dr. Rodriguez, and the Technon Clinic in Barcelona. He also dedicated his specialty at the in cosmetic facial surgery in Virginia, as well as the Manhattan Eye, Ear, and Throat Hospital in New York, the Polanco Rhinofast Clinic in Mexico, and all of his medical education has been focused on orthognathic and facial cosmetic surgery. And he worked for 5 years in the Vall d'Hebron University Hospital in Barcelona, where he headed the orthognathic and craniofacial deformities unit. And since he's also acted as professor at the Faculty of Medicine of the Autonomous University of Barcelona. And like I said, is now a surgical member of facial team since 2015. So welcome, Dr. Gutierrez.
Thank you very much. It's my pleasure being here.
And Octavio, Dr. Octavio Sintra from Brazil, also an oral and maxillofacial surgeon who works in Sao Paulo, and completed a fellowship in maxillofacial surgery at the Southwestern Medical Center in Dallas, Texas, in the United States. He is one of 5 members of SORG, which the Latin American group, which is a prestigious investigative team of scientists known as the Strasbourg Osteosynthesis Research Group. And he's also the vice president of the South American ARNET Foundation, which began in 2013 to help disadvantaged people access orthognathic surgery. And he maintains his private practice, strictly focused on orthognathic surgery in Sao Paulo, Brazil. So thank you, Dr. Sintra, for coming as well. It's a pleasure. And now we'll begin, I believe, with you, no?
I guess so.
So if you would like to share your screen.
Sure. And let me just...
And the transmission to Instagram may also begin. And I will pipe in every now and again to let you know if there are questions from some of our listeners.
Let me just open here before we start. And
so Octavio, I'm trying to go live through Instagram, but there are some problems with the connection. I think it's too many people trying to connect.
Yeah, it's saying for me to try to come back later in the Instagram, right?
Yeah, let me do it again.
Yeah, I'm just here waiting for you, and then you can start.
So we're going to try to go live again.
Okay. Well, in the meantime, I'll just remind our
live.
spectators here in Zoom, transmitting live to YouTube, that you can just write your comments down here in the chat. And if you're on YouTube, unfortunately, this is not an interactive platform, but you can click on the link in the description, which will bring you here to the Zoom chat.
So should I go, or you want me to wait for Instagram? It's up to you guys.
Try to join in Instagram. I don't know if, I think there are some problems with the Instagram live.
Yeah, me too, because it's saying, let me go. Okay, live, facial team. I'm going to facial team, right?
Yeah.
Yeah. It's trying to be on, but no. No. We are having some problems
Instagram.
with connection. Try again later. It's saying in the cell phone.
Yeah, I think it's overloaded.
It's up to you. If you want to go through here only through YouTube and Zoom, or want to wait to have the opportunity to broadcast also in Instagram.
Maybe we could try again on Instagram in a couple of minutes.
Yeah, okay. Yeah, go on.
And this talk will be recorded, so it can always be shared later on Instagram, and we can do a little apology for the technical issues that arose that impeded the live on Instagram.
It's always like that. During the test, works perfectly.
Yeah, this is typical. Technology happens to do this to us, but at least we're live on YouTube, and people can still click on the link to come into the talk here.
Anyway, I have my cell phone here pointed to me, and so just let me know if it's the time to try again with the Instagram, and then I'll do it. Okay. So may I share my screen now? Okay. So just before I go, I would like just to say that it's not only a huge pleasure for being here with Javier and with the facial team, because those guys are amazing. We started to do some lectures and some presentations and conference together about 1 or 2 years ago, but I know how hard they work and how they do a good job over there in Spain. And somehow we were connected through a very special group called Orofacial Group. That is a group that was formed by a dentist that is, in my perception, is a visionary called Christian Coachman. And the Orofacial Club was invented to highlight the importance of the interdisciplinary treatment planning. And so that's why me and Javier, we found that somehow a window open for the communication between orthognathic surgery, things that I do on my side, and facial feminization, things that they do, and they are experts in Marbella, Spain. Okay, so before I start, I'd like to just to say some stuff about orthognathic surgery, about the typical protocol that we use for dental facial deformities. So, okay, my screen is on. Yes? Okay. So let me just show here. This is a typical patient that comes from orthognathic surgery. Let me just put my camera in the right, but okay. This is a typical patient that comes in the first appointment, and the patient is not happy with the facial appearance. The patient is not happy with the bite, and something is wrong, and is not only an orthodontic problem, is not a dental planning. So as we can see here is a young lady, and her problem was related to the development of the mandible development and the support of the chin. And if you look to the bite in the right photograph in the slide, is a class 2 occlusion, which means there is an occlusion that is like her position of her lower jaw. The lower jaw didn't develop as much as it should. So that's why we need to coordinate somehow the dental planning and the facial planning in the same way. So if you look to the side of the bite, it's not a big deal, but if you look to the patient during smile, we can see that the projection of the lower incisors is not good. So the lower incisors is too far projected forward. And so that's why the orthodontist should put those teeth back to the base of the bone, to the mandible. So some orthodontic preparation should be done. And then we have how to do those measurements and those requirements in the software. So this is a software related to the planning, where we can see the correction of the low inclination and inclination of the lower teeth according to the bone, as you can see here in the highlighted area. So if you compare pre-ortho, before braces, and post-ortho, now we see braces in the photo in the right side of the slide, we have a much bigger overjet in front, because now the low incisors, they belong to the base, they belong to the mandible. And now the patient is going to be ready for the mandibular advancement, where we have the intention to correct the function and the aesthetic in the same way. But I'm talking about function here. Basically, I'm talking about the bite, the correction of the bite, the intercuspation of the teeth, and also with the airway patency. Because if you move the mandible forward, you're going to open the tunnel of the airway that is constricted before because of that malpositioning of the mandible. So this is the comparison between pre and post. And in the zoom photo, you can see that in the upper arch is everything okay. The upper lip relation, the upper teeth lip relation at rest, and the volume of the lips as well. And here is the patient after surgery. So the mandible was moved forward, and now we have a much better support of the lower lip. The lips are closed, support of the chin. And that patient in the right side of the slide compared to the patient in the left side of the slide, you're going to breathe much better. You're going to have a much better intercuspation and function as the gain of the statics in the same way. So a frontal vision of the patient, definition of the inferior border of the mandible, 3/4
Octavio,
view. Say it, okay.
Excuse me, Octavio, can you try to join Instagram? I don't know if it's possible for you, because people are not, they are telling me that we are visible in Instagram right now. I'm not sure, but people cannot see you. Just try to get through.
Let me see.
And connect.
I'll try again.
In my
Tell
mobile
them,
phone is not working.
Tell them that is because I'm very shy. No.
Nope. Okay.
No.
Yes, we will
Let me
forget
try
about
again.
that. I have just shared the link to Zoom. We are live in YouTube too. So
Yeah. Look, when I try Instagram here, I have that message. Can you see that? Wait.
I cannot see it, but I imagine. Yeah, it's Instagram, always the same. It's fine. Thank you.
Okay, you can interrupt as much as you want. No problem. And then, so coming back to our patient. So this is the 3/4 view of the patient. And this is the new bite. So it's a functional static correction at the same time. So here, I'm talking about interaction of orthodontics and surgery in just one case, just one patient. And that planning should come together. So this is the typical orthosurgical treatment. In the other hand, in other patients, it's not possible only to have two specialties. So that's why the beauty of this planning, the beauty of this science, because we can involve specialties as much as we need. So another young patient, another young lady, class 2 patient, no projection is not good. The projection and the support of the chin and the lower lip as well, somehow related to the same perspective and perception of the first patient. And this line here from the chin to the neck was her, at that point, was her main complaint. So overjet of a class 2, cephalometric preparation, inclination of the teeth, correction of the low inclination, braces in, and simulation of the surgery. So for that lady, the perspective and the surgery that will follow will going to be mandibular advancement, and in the same way, genioplasty. So everything in the lower arch, right? But somehow I put the plastic surgeon together with me to do a cervical surgery because it was too much fat tissue in that neck area. So it was not possible to define and to have a very good contour of the neckline, and not even in the chin with that fat tissue inside. So here we can see the comparison between pre and post. So now we have three specialties. We have orthodontics, we have maxillofacial surgery, and we have plastic surgery in just one patient in the same way. Another thing that I think is very nice to understand and to listen is about faces, how they age. Well, how is the aging process of the face, and how is this development of the aging process? Of course, that facial mask with the aging process, you're going to have loss of tension, less elasticity, and less volume. So what happens to the upper lip? The upper lip comes down with the age. In the other hand, what happens with the upper teeth? The upper teeth, they're going to suffer from worn, abrasion, attrition, and erosion. And so the upper teeth are going to come up. So with the aging process, it's very common for the upper lip to come down, and in the other way, for the upper teeth comes up. I don't know about you guys, but here in Brazil, my patients, they can be older, they can be ugly, but never older, never. They hate it. So this is a very young lady, 19 years old, where we planned biomaxillary surgery because of that face that was not according to her age. And now this is a rotation of the plane of occlusion and clockwise rotation. Now it's possible to understand what happened with the facial mask and with the upper lip. Now we have more volume. We have a face that is much more related to a lady with 19 years old than in the other photo in the left side of the slide. So this is possible with the orthognathic surgery. You have many possibilities, but it's possible to deal with the response of the facial mask. It's possible to deal with the airway, with the opening of the tunnel of the airway, with the function of the bites and the TMJs in just one shot. And so that's why somehow when we started to do conference together, presentations in the same conference, talking about interdisciplinary treatment plan, we found out that feminization and the new contour of the face can have somehow something in between the orthognathic patients and the transgender patients in the same way. Okay, so the resume of this patient: no orthodontics, skeletal surgery, muscle management, and so facial results. So now I think that I'm gonna leave my part as here, and then I'm gonna stop sharing, and then I'll go back to Javier for his considerations, and then I come back again. Let me just come here and stop sharing.
So I go on with my presentation, Octavio?
Yeah, sure. You can do whatever you want now.
Oh, we have some questions. Would you like me to shoot some questions now, or should I ask them at the end?
What do you think?
I think maybe it's better at the end, but I don't know, whatever you want.
Yeah, too. I guess you can do it in the end because you have time for that, right?
Okay, well, let's hold all the questions for after then.
Okay, sure.
Yeah. It's not going to be very long, so. Can you see my screen?
Yes.
Yes.
So hello everyone. As I don't know if how many people were watching while we had the introduction that Lilia did. We have had some problems with the connection to Instagram. We apologize for that. I have been thinking that maybe this recording we can share it tomorrow in our story so that people can watch it. Okay, so I think we are going to fix it like that. I would like to introduce myself. I am Javier Gutierrez. I'm one of the surgeons of Facial Team. Facial Team is a surgical group which is located in the south of Spain, and we are a real surgical group. We are more than 30 people working together to make the experience for a patient of a surgery much easier for the patient, for those patients. So we are more than 6 surgeons. We are a lot of people working. We have a complete group of coordinators who look after the patients from the first connection to Facial Team until 1 year that they are just released from our hands, and is the most important part of Facial Team. We also have our nurses, our marketing department. So as Lilia is here representing them, a lot of people in the administration, TNI, R&D, psychologists, physiotherapists. What do I want to say with this? We're a multidisciplinary team. So yes, we're focused just on the face, which is a very small part of the body, but it's a lot of sub-specialized people working together. Okay. I would like to talk a little bit about the bone itself, the skull, so that we can have an idea of the differences between male and women. It's important to say that Facial Team, for whoever that don't know, it's just focused on facial feminization surgery or facial gender confirmation surgery. This is where working and helping transgender women. Normally, we take care of male to female patients. So when they require and decide to have a surgery on their faces, we are there for them. So it's important for the audience to understand the differences between the bone in male and women. So normally our features are given by 2 different things. The first would be the primary aspects that are related to the craniofacial structure. So it's related to the bone, what we have below our skin, our muscles, our everything is the bone, which is going to be the scaffold for the rest of the tissues. So when we are modifying the bone structure, we're going to get such powerful results for our patients and long lasting. And the most important thing, even for us, for the surgeons, is that they're going to be predictable. What do I mean with this? Predictability is very important in surgery. And it is when you want to do one thing, you know how it's going to be in the future. It doesn't depend on factors like lack or how the body heals or whatever as the soft tissues. Normally, when we change the structure, the bone, the soft tissues are going to readapt, and we know how they're going to readapt. So we can sculpt the bone as much as we want and as much as it's safe to get what the patient is aiming for. So there are like very important difference between male and women skull. This the dimorphism is created when we are during puberty. So when the hormones start their action, the bone starts development. So when testosterone is working, is when everything develops. Until that time, the skulls are almost equal. And what does it happen? All the bone normally is focused in some specific regions of the face. Normally, it's focused on the supraorbital ridges, just above the eyes, which is called the bossing. So the forehead treatment is going to be very important for those patients. Also, the cheek area is quite different. Normally, male patients have a very important structure. So the bone is very heavy. It's a good amount of bone in the cheek area. And women normally have like less volume on that area. On the other hand, the soft tissue on women is stronger, is bigger. So we have more fat on the cheek area than male patients. So that's an important difference too. And then structurally, we have a big difference on the lower jaw. That is going to be mainly focused on the back of the lower jaw. So the angles, normally a square and powerful angles are related to men, and also on the chin. The chin normally is higher, more square, and with more quantity of bone on the parachin. So next to the symphysis, the parasymphysis. And of course, there are a lot of small difference that I'm not going to talk about because it would be a little boring. So you can see the differences on my screen. And here are the secondary aspects, which are also very important, but these, we don't need to treat them with surgery. We can treat them by hormonal treatment. So this is the difference between one patient and the same patient right after 1 year of hormonal treatment plus other facial hair removal techniques such as electrolysis or laser. So pay attention to how different a face can look like without surgery. We're going to find difference between the hairline, the hair, even the quality of the hair, the type of the skin is going to be thinner. Okay, the fat distribution, normally after a year, there's going to be a redistribution for the fat. And this is another example of that. We have this powerful change, which is only related to the hormonal treatment, okay? So as I have been explaining, we're going to be focused on the specific features of the skull. So mainly we're going to work on areas like the forehead, as I mentioned. With the forehead, we are referring to the hairline, the forehead bone itself, but we can also modify the orbital rim, the upper part of the orbital rim. We're going to be able to change it with surgery. Of course, the nose, if the patient has that need, we can change the structure of the nose and also the cartilage and make them more delicate, more feminine. As we saw, the lower jaw is going to create a big change. Then we have the Adam's apple, also the upper lip, fat grafting. There are a lot of possibilities. The main goal for the lower jaw is represented here in these two images. On the left, you have that typical image of a square chin, and this is what we are going to look for. To look for this oval shape of the lower jaw. This is our experience. As I mentioned, we're a group which is completely dedicated to facial feminization surgery. It's our day by day. We operate like 4 days a week in 2 different operating rooms. So we have a lot of experience with so many patients. And as you see, the forehead reconstruction surgery, the chin contouring, the lower jaw contouring are the surgeries that are performed the most with the rhinoplasty. And as we are talking with Octavio, who is a very important orthognathic surgeon, we were just trying to see how can we introduce the topic, and then how we can get different ideas of different approaches, but with the same goal. Okay, so this is not orthognathics. When we are talking about operating the lower jaw on the patients, we're talking about operating the lower aspect of the mandible to reduce the accumulation of bone that the testosterone created during puberty. So we're going to be focused on that aspect. This is not a typical aspect that many surgeons do, but you can also combine these techniques with the traditional orthognathics, which is going to be very, very powerful for the results for the patients. So we have developed, as Octavio mentioned before, now we cannot live without technology. So we, at the beginning, when we start doing these surgeries, that was very difficult. It took a lot of time to be comfortable with the surgery. And despite the osteotomies, the cuts on the bone were very, very good, we needed like a safety measure to assure that what we were doing was exactly the same on both sides. We were removing what we have on our mind. So we take profit of the technology that nowadays exists, and we created those tools. So since that time, it's like 2 years ago, since we're using them, our day by day is much easier and the results are much better. So here you can see an example of a patient that has operated her jaw. Look at how square her jawline was, how strong, how square. And now, after surgery, some months after surgery, you can see that roundness, that softness is much more feminine, much more delicate. And here is the profile image, where you can see how the prominence of the chin has been diminished, and also that angle here has disappeared. Okay, the neckline still remains being very nice. And here there's another example of what FFS can get in a patient. So see, it's still the same women, but with very delicate features, very soft. She's keeping her identity, her core identity. Is like trying to get the image of her twin sister without looking artificial. And these are images that we can use later if for discussion. So I will end up here, and then if you want, Octavio, to proceed with more explanation, or if you want, we can start. I don't know, Lilia, how many questions we have. So
you're muted.
We
Yes.
have a few questions, but there's time.
Okay. So so now it's back to me, right?
yes.
So just for people to understand how we started this interaction between feminization surgery and orthognathic surgery, basically, in feminization surgery, the bone surgery is related to the recontour of the bones. It doesn't matter which bones, mainly as Javier just showed, in the supraorbital area and contour of the mandible and the chin. In the other hand, from my perspective, in the orthognathic island, that facial bone surgery is not changing the contour of the bones, it's changing the position of the bones. And so we started to see that change position and change shapes, somehow they have a combination, because we have basically two options. Patients that want to do a feminization surgery that have the necessity for changing position, and patients that don't want to do feminization surgery, regular orthognathic surgery patients that needs a patient that need a kind of a recontour of the bone, like a feminization surgery, even though there is another, is not a patient that want to change his or her sex, right?
Mm-hmm. Yeah, that's it. That's the
actually, Javier, before I go, I do have a question for you, if you don't mind. You spoke a little bit about the use of medications and the transposition of the fat tissue in the face. And do you have a kind of a prediction for that? How going to happen? In which part of the face you're going to concentrate the fat tissue? Because I see that patients, they want to then have more patients in the middle thirds. In the other ones, you're going to have more fat in the lower level. So there's somehow any tool or prevision and how it's going to happen.
We are not managing the medication of our patients, so that's something that the endocrinologist controls. So we cannot have the knowledge. We have not done any, but it would be an interesting paper just to study how the different hormonal treatments can induce fat accumulation in such determined regions. We don't know. We always recommend our patients to start hormones and be 1 year. If they can stay for a year with the hormone treatment, normally the outcomes that we get are better, but we cannot predict where the fat is going to be accumulated. As you said, we have found that some of them accumulate on the cheek area, but others go to the buccal area. I think that's more related to the genetic of the patient, to the heritage of the patient, of every patient, and how they accumulate fat on their faces. So if we have a chubby face, and with a hormone treatment, maybe she's going to have a bigger accumulation of fat on that area. But we don't have the chance to predict where it's going to be.
Yeah, I see. And do you think that also this kind of treatment is a possibility to be a preparation for the surgery? For example, it's possible to treat a patient for 1 year of medications and hormones and then wait for that response and then do the planning of the surgery after it.
Yeah, it's normally how we do it. And we normally recommend that plan if the patient wants to have more volume on the cheeks and they have not had a regular base of hormones for 6 months as a minimum. We don't know how the hormones are going to affect their face. So we say them, okay, this is going to be because we know how your bone is, but we don't know what is going to happen on the soft tissues with the fat. So if you want to add more fat here, wait for the hormones to work, then we reevaluate. If you want, our philosophy with this normally is like I'm going to explain you. The work on the bone is going to create such a big change on their faces that many patients don't have the need of adding more volume on the cheeks because everything has been softened. So imagine you have a very big bossing on the forehead and a very big nose and a very square and powerful jaw. You smooth that. So you are going to have very nice result on the lower jaw, very delicate nose, very feminine without the bossing. Automatically, the region that pops out are the cheeks. So many of them, after that, they say, okay, I have thought about that, and I think I don't need a cheek augmentation. And on the other hand, when you see like there is a hypoplasia of the maxilla or the upper jaw, you say to the patient, okay, we're going to try to camouflage it, but for sure you are going to need that. You're going to need volume on the malar bone, and maybe if you have a retruded maxilla, you may need that. Of course, the evaluation for the need of an orthognathic is always done first. Is the thing that we always evaluate. If the patient has a dentofacial deformity because a lack of development of the upper maxilla or the jaw, we tell them, okay, this is something you can treat locally because it's going to be easier for you. You're going to have the opportunity to go to your orthodontist and then meet your surgeon. There are a lot of good surgeons wherever you are because orthognathic surgery right now, nowadays, is very extended, very well-known surgery, and there are so many physicians doing it well. So treat that first if that's what you want, and then we're going to reevaluate your face, and then we are going to plan your surgery. And we normally do it like that because, as you know, orthognathic surgery you mentioned before is about moving three-dimensionally your bones to create balance, to create harmony on the bones. But the contour is not going to change. So we prefer them to be moved first, and then if there are steps between the cuts of the osteotomy, we can soften them, we can get a very nice jawline, a smooth transition between all the cuts. So that's normally our plan.
Yeah, I see that you have somehow some patients that probably you're going to ask for just one shot, and patients that they need orthognathic surgery and they want to do moving bones and recontouring the same way at the same time, just to have just one shot surgery, and of course just just one follow-up. So that's why I see that if it's possible to do the reverse treatment planning, as I'm going to show right now, if you plan the result at the ideal end and then you come back to the initial, is it possible to be very precise into doing just one surgery?
Of course, that's possible, unless you have a very big need for a full feminization. Imagine you have to do the orthodontic treatment, the preparation, and then you are going for the surgery. Imagine it's a Bimax, so you need at least, I don't know how much does it take for you for a Bimax, but in our hands it's minimum is 3 hours. So we have 3 hours for the Bimax plus the contourplasty, which will add 1 extra hour, imagine. So it's 4 hours. But for a full feminization, we need forehead, a couple of hours, nose, 2 more hours. Then if we have to do the Adam's apple, is 1 extra hour. And then if the patient needs a hair transplant, adds 4 more hours to the plan. So that's impossible. It's unsafe. So we have the limitation of time, but
what is the limit that you have your time? In your perspective, what do you think is the limit in timing, in surgical timing?
In timing, normally we try to avoid surgeries longer than 8 hours. 8-9 hours, it's fine, but after that, normally patient takes a lot of time to recover. The recovery is a little more difficult for the patient.
Yeah, I think that is about 6 or 7 after that timing, the quality of the surgery as well. And it's not that
sorry, Lilia, just let me end this and then we go on with the questions. I think, Octavio, a good combination would be Bimax plus contourplasty plus forehead surgery. That would be great.
Without hair.
I think it's more without hair.
Yeah,
for
because
example,
only hair takes 4 hours, right?
For the forehead, it's 2 more hours. And
No,
if you want to add the nose,
hair. No, I mean hair transplantation.
The hair transplant normally takes 1 hour for doing the incisions where the follicles are going to be inserted, and then the patient is going to be awake. So the incisions are performed with the patient's completely asleep. with the intubation. So she's waking up, and then we continue with the hair transplant like 3 or 4 more hours. But the patient is sedated, a little groggy, but she is not feeling pain, but she has to be there, which is uncomfortable.
Okay.
So we have quite a few questions building up here on YouTube. Shall I shoot a couple of them out here?
Yeah, sure. I'm just want to show something before we go for questions very fast. As we are just talking about the combination of those techniques. One young lady here that I operated a couple of years ago.
Sure. And could you just clarify what Bimax means? Because I think some of our listeners on YouTube probably don't know what Bimax means.
Yeah, Bimax is a bimaxillary surgery. Surgery in the maxilla and in the mandible at the same time. So that's why it's Bimax. You can have a single, only the upper jaw or only the lower, and both together is a bimaxillary surgery. Okay. So this case here is a girl that, do you guys see my screen now?
Yeah, we see
it.
Okay. It's a very typical case with the conjugal hyperplasia. So she developed during the teenage age a development that was very asymmetric because of the conjugal hyperplasia in the right side of the face. So that's why she developed that kind of asymmetry and then kinds of hemimandibular hyperplasia. And so this is a comparison between pre and post. And of course, that is not possible to get the new shape of the face with symmetry. And I always like to comment about biological symmetry and geometric symmetry, because biological symmetry will never be a geometric symmetry. But the perception of the patient afterwards is symmetric. So this is how we judge that the result was good. And so to have this kind of situation of the result is not possible only moving jaws. So we have to move the jaws. Is a bimaxillary surgery, as I just mentioned. I had to move the maxilla, the mandible, and the chin in the normal and regular protocol of orthognathic surgery. But in the same surgery, I have to deal with the contour of the jaw, the contour of the mandible, to recontour and to get the balance, to get the symmetry, as in the same technique as in the feminization surgery. So that, of course, that we have to predict the timing of the surgery, as we were just speaking here. And so I think that it's possible to do everything in just one shot. Avoiding timing over that 6 or 7 hours, you're gonna be okay. More than this, probably is better to select 2 timings and to do in 2 different timings for the surgery. So this is the patient, pre and post, and here the comparison between CBCTs. So now it's possible to see that comparison with the mini plates and the new contour of the whole face, that the recontour and the position of not only the maxilla and the mandible were achieved. Was maxilla, mandible, chin, mandibular contour, mandibular body angles, and cheekbones, everything from the orbits, below the orbits, were moved. And here it's possible to see the new contour of the mandibular body and the mandibular angle. So since the chin to the angle of the mandible, we had to do some work and to move the position and also the contour. So this is a perfect combination of those 2 techniques. So this is another patient, is not the topic. So
yeah, that's it. That's it. We also operate some orthognathic, not as much as you, of course, but we cannot think on orthognathics without the contourplasty at the same time. We always do it because it's going to improve a lot of things. Of course, the symmetry, if you have also a case like that, that's unavoidable. You cannot end the case in a different way. But in all the cases, we always approach the lower border to make everything softer, smoother. And our results are very nice since that.
Yeah, sure. This is the perfect way to make it. So you can predict the result of the surgery before doing that. So this is the tricky part. So the thinking process of the planning is tricky. So how to proceed with the surgery is technical. So surgical technique, you have to practice, and if you have numbers, and if you practice, you're gonna be you're gonna be a very good surgeon. But the thinking process of how many procedures they can be done, they can be performed at the same time, and how is the right way to build that plan and to build that surgical technique for the patient. This is the most important part. So I used to say that for my last part of my slides, that I used to call this as reverse designed treatment planning. Why I called reverse designed? First, many other specialties in dentistry, they do for a long time. For example, implantology, prosto and restorative, orthodontic aligners, the use of aligners to do orthodontics. So what they do, they visualize the ideal ends of the treatment before touching the patient. They visualize and do whatever is necessary to get the ideal end. So as soon as they have the ideal end, they do a step back to plan the treatment. And so they give even one step back more to go for the initial. So this is the procedure sequence. The procedure sequence is a very straight follow-up from the left to the right, from the initial to the end, of course. But the thinking process is completely the opposite. Is performing the visualization of the ideal end and coming back and building your procedure. So for example, this boy here, so about his face, the main problem is the projection of the chin, right? So the chin is not well supported and not well developed. So in the regular way, what we do, we go, for example, for this protocol, and now it's possible to predict what you should come with orthodontics, for example, as you can see here. So this is about braces or aligners, whatever. And then this is the post-ortho treatment. So after the post-ortho treatment, moving jaws and getting a new bite. So now the yellow is post-ortho plus orthognathic surgery procedure, moving bones. And then after the orange with restorative, with new teeth, new shape, new colors. So now in the orange, we have orthognathic, and restoration. So this is how we build. And so we do the planning of the surgery and we do the prediction. So this is the prediction of the surgery and the results of the new array, the new face, the new bite, without touching the patient. So we have everything in our table like a recipe. And now you just have to use the right ingredients and follow the cookbook to get the results like this, like baking a cake. I'm not a cooker, but I know some.
So wonderful, Octavio.
Yeah, so let me just stop sharing, and then it's very nice to see that. No, thank you guys. So just to conclude, it's very nice to see that they have that combination, that possibility, because I know that lots of patients here on my clinic, they want and they need anything else. They need more procedures, some recontouring, some perspective that is different. And in the other hand, feminization patients, in the same way, they need moving jaws sometimes, not all the time. So if you have the opportunity to open your mind for everything and to open your mind for all the combinations of procedures and what is possible, what is not possible, during the planning, of course, that everything is possible. In the software, you can do whatever you want. But just open your mind for the ideal and see if it's feasible, if it's possible. If it's possible, go for it. If it's not possible, try to adapt as possible or as much as you can. So that is the message.
Well, one of the first questions that came up today has to do with the order in planning and the time that patients should wait in between. So we have one person here, Christy Woods on YouTube. We've got a lot of questions on YouTube. She asked, it's really, I guess, for Dr. Gutierrez, because it's asking about male to female HRT. How long should they be on hormones before having FFS?
hormonal treatment is not mandatory. Okay, so it's up to the patients to start it or not. If the patient decides to go further with hormonal treatment, we normally recommend at least 6 months because it's the minimum time required for the effects to appear. So 6 months as a minimum, 1 year ideally.
And is there an age limit to when a patient can have facial feminization surgery?
Once the development of the skull has ended, the patient can operate the bone. So normally it's around 18, it depends on every patient, but between 16 to 21.
Okay, but there's no maximum age, or sorry, minimum or maximum age, right?
No, maximum is just your health status. And minimum,
Javier,
of course,
what's your oldest patient?
Our older patient, Lily, I think is a patient who was 74.
74. Right? Yeah, 74. We've had a 73-year-old patient. So as long as the health status is stable, under control, then this hasn't been a problem.
Good.
That's
on my side, I have my oldest is 76.
Another patient.
Wow. For an
a woman from for Orthognathic, a woman from Portugal.
Wow.
That's great.
Another patient asked about weight and weight loss. If they are on a diet and losing a lot of weight, how should they keep that in mind in terms of their planning, and what is that? Why is that important for you in terms of planning which procedures on the face will be necessary?
Yes, of course. If patient has lost a lot of weight and she wasn't thinking on operating the lower jaw because it wasn't visible before that time, and she has lost a lot of weight, and imagine you have a surgery of the forehead and the rhinoplasty, and the patient, when she had the consultation, she was not on a diet, so she doesn't have that need. But once the surgery time is coming, and she starts thinking, okay, I don't like my jaw because now I can see it, the plan can change. Of course, we always do the final and definitive plan a few days before surgery. So that's something to take into consideration. And on the opposite, it's exactly the same.
Absolutely.
Or if the patient is thinking of having a lifting in the future, because I don't know, Octavio, if you have this type of patients who have a lot of bulkiness and a lot of soft tissue, the flesh is like very thick. So that makes impossible to see what is below that. Yes. But some of them go for a Bimax, for example, because the Bimax effect, the advancement is like a lifting effect. Everything is so tight after surgery because it has been advanced that the jawline is very evident. And right after that, maybe the patient thinks, okay, I will go for the surgery on the jaw because I'm going to do a lifting in the future. That's a possibility.
Yeah, I would say that with the bimaxillary advancement, we used to say that Bimax has an effect like an inverted facelift. Because what happens with the facelift, the plastic surgeon is going to pull back all the facial mask. The facial mask is going to go back to the bones. But if that patient has any kind of retrusion of the bones, if it's a bimaxillary retrusion, for example, you're going to pull back the facial mask to that retracted bones. So the right way to perform the surgery is to avoid that kind of traction of the facial mask and to move bones forward. And you have a very, very much better result. And it's a facelift from inside, not from outside.
That's it. Lilia, more questions?
Yes, there's quite a few questions here. Hang on one second. Somebody asked, going back to the hormones, somebody asked whether hormones have any effect on the bone or just on the soft tissue.
Yeah, just on the soft tissue. It's not going to modify the bone structure. So what we see on the CT scan before surgery is what we're going to have always, unless the patient has an accident or a surgery. But what it can change is the soft tissue. And there are patients who doesn't have any effect on the face. They only have the effect on maybe on the chest or maybe on the bottom or whatever. But it depends on every patient. More questions?
Yep. Okay. So Dr. Noor on YouTube has asked, she had her FFS in March, and she feels that her upper and lower jaws don't align when she closes her mouth. What would you recommend in this situation?
First of all, she has to be evaluated by an orthodontist or an oral maxillofacial surgeon. So once that is done, she's going to have a clear idea of what is the need. Maybe with orthodontist, braces, and traditional treatment without surgery can work. If the problem is on the bone structure, you will need Octavio.
Yes.
Okay. Okay, and let's see, we've got a few more questions. If somebody lives out of the country, do they have to get imaging performed and sent in or done later? I think by imaging, they're referring to x-rays and that kind of thing. So if they were to go move forward with this kind of surgery in Brazil or in Spain, do your clinics provide this, or is it something they have to bring with them?
Octavio, if you want, then
No,
I will talk about our clinic.
When the question was performed, the sound was a little bit cut. So just make it again, please.
Sure, I'll repeat the question.
Interruption of the sound.
Sure, the question was regarding imaging. Do you provide your clients with the imaging in-house, or if you have patients coming from abroad, for example, do they have to take it with them, get it done in advance, or?
Yeah, no, okay. So we do everything in-house. So it's not only the X-rays. Actually, it's not X-ray anymore. We do CBCT with a very special kind of tomogram, facial tomogram. So the protocol actually is a little bit more than this. The protocol is to perform facial photos, CBCT of the full face, and scanning the arches, scanning the models, scanning the teeth to get models that are going to be printed. So we have everything in-house, the tomogram, the printer, everything, the camera. So as soon as the patient comes from the first appointment, we used to do everything in that shot.
It's the same in facial teams. The patients don't have to worry about anything. They just came here and we do the evaluation, full evaluation of everything. 3D photos, CT scan, whatever needed, intraoral registries, if it's an orthognathic. Yeah. And right after surgery, they're going to have a new CT to check everything that was performed is correct before they leave the country, so that they can go and travel safe. And
Javier, I have a question about this issue. When patients come, because I know that you guys have lots of patients from abroad, and when patients come from the regular, I would say, of course, that depends on the surgery, depends on the patient, the age, but regularly, the normal kind of FFS surgery, and how long patients they should stay with you guys in Spain?
Normally they come like 2 or 3 days in advance, because we have to do all these tests that we have been talking about, and the planning, preparative evaluation and everything. So they come to the surgery and they spend 2 nights at the hospital normally for a regular surgery. And after 2 nights, they are released to the accommodation. We have this is not an official accommodation, but it's a recommended place to stay, where they have the nurse attention and everything.
Oh, nice.
And they come back to the hospital.
Home care over there.
Yeah.
Okay.
And 8 days after surgery, they come back to the hospital for stitch removal, fine evaluation, and do all the advices for the post-op care and everything. So I would say 12 days after surgery, 8 days after surgery, 12 days after they come back to Spain, they are free to go home. Normally they spend 2 weeks, more or less.
Yeah,
and
so 2 weeks after it's possible to get a plane and to go everywhere.
Yeah.
Okay.
They look very normal. As you know, once we have started with the PSO surgery, like 5 years ago, everything changed. So they don't get very inflamed. So the
This is a
photo
turning point.
period with all the, we also use the hyalotherapy, so with a cooling mask, physiotherapy, lymphatic drainage massage, and elastic band compressions for the post-op. So the inflammation is not very, some patients get very bruised, but it's the only thing. And as you know, it's not a painful surgery.
It's not a problem to go back with the bruises, right? Yeah, basically, I do the same here. I request them to stay here at least for 2 weeks, but sometimes they stay 1 week more. So at least 2, but sometimes they stay 3 weeks. But after 2 or 3 weeks, they can fly back.
I think orthognathic is a little trickier than FFS because you have to be sure about the occlusion, maybe some elastics.
Yes.
So you need to.
Yeah, what I used to do, patients from abroad, and I have a guy that are gonna take care of the follow-up in the patient's place. So for example, patient come from a biomaxillary surgery, stay here for a couple of weeks and fly back to USA, for example, to another country. Over there in that place, we have a connection and another surgeon or an orthodontist. We're gonna take care of the use of the elastics. They're gonna feed me with information, photos, and then of course, that with technology is possible. Okay.
Here's an interesting question for both of you. And since we're discussing facial bone surgery and how its combination with plastic and cosmetic surgery and other treatments could raise the level of results. One person here on YouTube asked, can I look like a perfect lady on TV with perfect features? Is that possible?
Regarding feminization?
Regarding any kind of surgery, if we're talking about plastic surgery, looking to get to your best self. So there's this person's asking, can I look like a lady on TV who has perfect features? Is that possible?
Okay, if she...
This question is tricky.
It's a tricky
to look like Angelina Jolie.
Patient comes to the office with a photo on his hands. It's not him or her.
we can get her best or his best version, of course. We can change the structure of the bone, and then we normally recommend our patients to split treatments. If it's related to feminization, we're going to treat first the structural part. So we're going to modify the bone. Then we're going to let the soft tissue readapt to the bone. So normally that takes a year and a half. And after that time, the patient is going to be evaluated again. So if she has some sagginess, or maybe she wants to correct the wrinkles, or maybe to correct the upper left, or do a nose job, or more cosmetic procedures should be performed later. That's our protocol, facial team's protocol. I know there are other surgeons that do everything at the same time. We don't like that because it's difficult to control everything, and there are some specific features that we would like to explain, but this is not the place. But our protocol normally is change on the structure, healing time, and go for cosmetic procedures.
Yeah, I would say that in orthognathic surgery, in my perspective, is basically the same, that we used to do everything the hard tissues before, and some little work in the soft tissues can be performed together, as I showed in that lady in the neck, in the cervical surgery. That surgery is possible to be performed together, but the right way to follow that concept is to correct everything related to the hard tissues, wait at least 1 year, and then go for the fine tune, and the fine tune the soft tissues and the facial mask in a second shot. And then basically is the same, is the best version of that person, is kind of a identity. Is very difficult to transform one person in another. So with the surgeries, with the facial bone surgery, it's really possible to get the best version of that person by herself.
Exactly. I think it's important. I brought up the question that was put out there on YouTube because I think it's important because it relates to expectations. We start with
Exactly.
a base, and that can be improved and get, like you say, Dr. Sintra, and to get as close as possible to the perfect version of yourself.
Exactly.
But you
With the,
cannot
with the
become
morphing in
person.
with softwares now, with planning softwares now, it's possible to do the morphing, and with the morphing, it's possible to watch the result of the surgery or the prediction of the results. So it's a very important tool for the communication. It's very difficult to communicate with patients about the results without softwares. So if you have the possibility to visualize the result of the surgery before doing that, it's very nice to have that communication with the patient and to get and to understand his or her expectations about that.
Thank you. Here we have a question. Someone who was watching the presentations earlier noticed that there was mesh in the skull. And does that mean that the sinus bone has been smashed or dismantled, or is it due to the thinness of I guess this is more for FFS, no?
Yeah, I think that's my question. Normally on the forehead bone, when we need to get very, very big setbacks of the forehead because there's a very heavy bossing on the forehead, normally that's related because of a very big frontal sinus with a very thin anterior wall. There are different techniques to correct that. I would say 95% of our patients get the type 3 reconstruction, which is the one that removes the anterior wall, keep it that piece of bone, and then place it back. When the anterior wall is a little damaged, or there is a small hole, or maybe there is no hole, but in the future, because of bone resorption that may happen, to avoid that in the future, to avoid an aesthetic defect, we are placing that type of meshes. They are very extremely thin. They are non-palpable, non-visible. The patient doesn't feel anything, but it's not because of the function of the sinus. It's because we want to avoid maybe in the future an aesthetic defect. Okay, I think we have had only 3 problems with the frontal sinus over 2,000 cases. So the rate is extremely low. It behaves very well.
Okay, there's some more questions coming in here. How bad is it? You mentioned this earlier, Dr. Gutierrez, but I'd like to hear Dr. Sintra's also advice on this, because some people have to have several surgeries. So, and sometimes they can combine the surgeries and sometimes they can't. So they want to know, is it better to have several short surgeries or have less longer surgeries? Since there's always the risk of anesthesia, and damage, and scarring, etc.
For sure that the intention is to have less surgeries, as many as possible. So if it's possible to do just one surgery and do everything in just one shot, this is the dream. So this is the ideal.
But
so
in orthognathics, what would be the maximum time, the length of a surgery?
I would say basically the same. Probably in orthognathic, we try to avoid surgeries that go over 6 hours, 7 hours. With 6 or 7 hours, talking about that issue, orthognathic surgery, it's possible to do basically everything. If you have to do TMJs, you have to do maxilla, mandible, chin, mandibular recontour, cheekbones, everything in just one shot, in one surgery. Probably it's possible to make around maximum time of 6 or 7 hours, which is good. If it's a health patient, it's not a problem.
Okay, here's a really interesting question about the simulations. You were showing us, Dr. Sintra, and Dr. Gutierrez also showed us and spoke a little of simulations. How precise are they? Can you talk in millimeters when using these simulations in planning?
Yes, of course. That I always talk to the patients and patients' parents that the simulation is a simulation from a computer, from software. It's not the real life. But the development of those softwares, they're very controlled. So the algorithms and everything that is inside, they have a lot of science behind. So I used to say that the result most of the time is better than the prediction. So we have now a work that we have been doing here in Brazil, where we are comparing the projection with the real results at least 1 year after surgery. And then we see that the results in the real life is even better than the projection. That, of course, that the patients, they want to take photos of the projection, they wanted to print it and take with them to their homes. But I used to say, though, pay attention and take care, because this is a projection from a computer. So don't grab to that result. And if you don't look exactly like this, it doesn't mean that you didn't have a good result. But we are watching exactly the opposite. Patients getting better than projection.
Is it the same for the virtual FFS, Dr. Gutierrez?
It's different because when we're talking about, we have to differentiate between a software for the planning, which was what Octavio was saying, and then the prediction of the outcome, the result, the morphine that he also mentioned is how the movement on the bone is going to be translated into the soft tissues. So the movement of the bone is going to be exactly that. Okay, you have also the possibility of having everything done customized, so you can print the guides and everything. So this is what we are using in, for example, on the lower jaw, on the lower border of the mandible. So that's very, very accurate. We're about to publish a paper which says that it's 99% of accuracy between the lower jaw, but the prediction of the outcome, which is the thing that the patient cares more about, is how this is. Okay, you have been explaining to me that you are going to remove that bone or whatever, but how do I going to look like? This in feminization is not very standardized, and we are using a tool which is tricky if the professional that uses is using just to try to convince patients to do things. Okay, we are working with Alex Heimer. Alex Heimer is a virtual expert that is, I would say she's the best in the world. I know that's crazy to say, but she has a lot of experience doing virtual simulation of FFS surgery. Okay, so she has been working with us for such a long time, so she knows exactly how far we can go with surgery. And we use the tool just to adjust expectations, as Octavio said before. We have this, we know how we are going to work on the bone. We know how you are going to look like on a photo, because that has to be done on a photo. She's an expert on 2D photo, frontal, 3/4, profile, and the patient can have an idea if maybe the lower jaw is something that she needs, or maybe how the effect of the eyebrow lift is going to look like on her face. But as Octavio mentioned, this is just a prediction, and this is not a rule. And if you don't get that result, it's something that you have to use against that. Okay, it's just an orientation. I think it's important, and we cannot talk about millimeters. We know that for the forehead, it's very accurate. For the Alex always say it's around 85–90%, and for the lower jaw, it's a little less than that. It's 80–75–80%. We are thinking on how to measure that, but it's tricky. But nowadays, with the 3D technology, we have a lot of work to do in this.
Yeah, the response and the result about the adaptation of the facial mask after a facial bone surgery may vary from one patient to another.
Mm-hmm.
And sort of on the same topic here, one person here on YouTube was asking about these surgeries in terms of ethnic features. So she's a Black woman, and she was wondering if you preserve her features, if that is true, or how do you go about this with patients?
That's something that has to be respected, because we want to get the best version of every patient. So you cannot convert Black women into a Caucasian or into an Asiatic. This is something that is like funny when patients come to us and I want to look like this Korean girl. That's impossible, because the structure is different, your phenotype is different, your soft tissues are going to behave completely different. So you have to be thinking on the phenotype that you have. That's something that should be respected.
Okay. Well, that's all the questions I have here on YouTube at the moment. I have some other questions here, but we're on almost an hour and a half. So
yeah, I think it has been
We
long
can-
enough. I don't know if I'm not in a hurry. If you want, we can
No,
start
me
go on
neither.
talking and talking.
This is a topic that we can stay here for the whole day.
yes, I agree. Well, I think that since there's currently not any further, we have a question here from Leanne on YouTube that says, how long is the normal wait list before you can have surgery? I think that's aimed, well, I guess it would be aimed at both of you. How long does the patient usually have to wait?
Now I have to wait for the coronavirus. No, so probably I think that now all the world is different in the whole planet, and probably you have to wait for a kind of normal situation, probably in August, I think so. And then after August, probably basically 1 month, I would think so, gonna be enough. So patients that can come in August, probably they can have their appointments in 1 month after, in September.
Okay.
For facial thing, I think we have a little, it depends, of course, on the surgery that the patient is thinking about. But we were working with 6 months of waiting list, more or less. I don't know how the coronavirus is going to affect. What I know is that we are going to work harder after coronavirus. We will have to operate more days just to catch up with the waiting list. But around 6 months is the rule.
Yeah, it depends on the combination of procedures. Okay, here we have, I thought I addressed this question earlier, but maybe not. It's been repeated here. So a person who's had surgery 2 months ago and notices that their jaws are not aligning as they used to.
Yeah,
and
we talk about that.
Yeah. Okay. So if you need further guidance, the person who asked this question, we can attend to you better by email. Okay, so write to us, orientation@facialteam.com.
Yeah, we can arrange a Skype if you want.
It's better to arrange a consultation. They're free and there's no waiting list really for the consultations, and they're done on Skype, as Dr. Gutierrez said.
Are you using Octavio the Skype consultation or video conferences? Yeah.
Yes, especially now I've been doing lots of online consultations, and it works perfectly.
Yeah. Nowadays it's a tool that everyone should use it.
Yeah, right. It's a good option.
Absolutely. There was a question from a couple of cisgender people who one asked about whether the incisions are placed in different areas depending on the gender of the person, and also a trans man asked about whether there's a surgery to make their forehead more masculine.
For the first question, normally we try to hide all. Yeah, we try to hide all the incisions. So for the forehead, normally we incise here on top of the head. It's called a coronal approach, which is completely invisible from the very first day because it's covered by your own hair. Then for the nose, as you know, the incision is completely invisible. It's between both nostrils, a small incision, and then inside the nose. Intraorally is the same in orthognathic. Everything is done for the lower jaw or the upper maxilla, everything is done intraorally. And the incision that could be a little visible is the one for the Adam's apple that is not over the cartilage, of course. It's always hidden somewhere between, just below the neck. So it's not visible on the frontal view, okay? The only incision that could be a little visible is the one for the lip lift. That is a line that is going to be placed here You cannot go in the nose because it would create a very weird effect. So that's the only visible incision. And the second question was about female to male surgery, I guess. There are surgeries to masculinize forehead. It's the opposite. Instead of removing bone, we have to add bone. And for doing that, we can use the combination of sculpting too, but also adding, there are like prosthesis. This material is called PEEK, P-E-E-K, which is working well. I don't know if what you are using for malar prosthesis, Octavio, are you using Pore or PEEK?
For cheekbones, you mean?
Yeah, it's the same that we use in the forehead. We normally use PEEK
to
the
do
lower jaw too.
Yeah, I use a lot augmentation in the cheekbones in orthognathic patients, especially when they have a retrusion of the maxilla, because retruded maxilla tend to have a retrusion and a lack of support of the cheekbones as well. So with the orthognathic surgery, you move the upper jaw, but it's not possible to move the cheekbones and to have a new contour because of that flatness. So in those cases, I use a combination in between hydroxyapatite. I do a kind of from Dr. Arnett, that the prosthesis that you do in the OR, and have to wait for a couple of hours to get to be rigid enough and to be inserted. The shape, yeah.
Yeah, but there is that possibility of adding volume.
Yes, to add or implants, MedPore, or there's a lot of possibilities.
Is that all, Lilia?
Yeah, I think so. I think I covered all of those questions on YouTube. If anybody has more questions, please declare yourself now. If we missed you, there's quite a few in the chat, but I think we got to most of them. Here, well, see, they're listening, they're paying attention to me. Just two more just came up. So if you're making the forehead smaller or a brow lift, won't the scar be at the hairline or is it invisible?
It depends on the case. If the patient has a long forehead and want to reduce the height of the hairline, like this is called a lowering hairline surgery, we need to remove some skin from here, and that incision should be placed over here. But if the patient intention is to correct the hairline because she has an M shape and it looks bigger here than here, and want to get this like closer to the brows, the incision is going to be performed here, and this part is going to be closed by hair transplant. So it depends on the case and how the hairline looks like. If the hairline looks very oval, the possibility of lowering is going to be better than doing the corona.
Right. This same person is asking now, but they heard that somebody else saying that it was preferable to have hair transplants instead of lowering the hairline surgically. Hairline advancement. That's what you just said, right?
Yeah. We normally recommend doing hair transplant and coronal approach for a forehead reconstruction and reduction surgery with a combination of hair transplant. I think it's less than 20% of the patient needs a hairline lowering surgery because of the shape of the hairline.
Right. Like mine.
Not like mine.
Thank you. Oh, thank you so much. People on YouTube are saying thank you and saying that we look lovely.
Thank you so much. Thank you. I think that this is just the beginning, right? First one.
It's a very good
first
initiative.
of many. Yeah, I guess so. Very happy for
so
being here.
should we close now and say goodbye to everybody? And I think this worked fantastic, and also apologize for the technical difficulties. Instagram seems to have a generalized issue, so we were not able to live stream, but for those of you who are seeing this in a recorded version, the replay, and we made sure that it got to you on Instagram eventually. So thank you so much, Dr. Sintra from Brazil.
Thank you very much. Thank you.
Thank you, Octavio. Thank you,
Thank you,
Lilia.
Javier. I hope very soon I can visit you.
Likewise.
Yes, whenever you want. And I want to go to Brazil too.
Whenever you want to. We're waiting
Take
for
me
you.
home.
So thank you.
everybody.
Have a very good night.
You too.
Thank you very
Cheers.
much. Take
We'll
care.
be back soon.
Bye-bye.
Bye-bye.
Stay tuned.